evaluate patients with obesity. We will talk about pathophysiology of obesity, FDA-approved and off-label medications, as well as pipeline medications, and share some resources for those of you interested in learning more. So this is a bit of a busy slide, but we'll try to break it down and to make it fun. This is the neuroanatomy of appetite regulation as it relates to gut-brain axis. So I'll start down here with the stomach. The stomach sends signals of either being empty or full to the brain. So first here we have the arcuate nucleus of the hypothalamus, which has receptors for POMC-CART, which signals anorexigenic behaviors or satiety behaviors, stop eating behaviors. We also have the agouti-related protein neuropeptide Y neurons, which trigger a desire to eat or more hunger. And these are really the two neurons that are majorly responsible for whether we increase food intake or decrease food intake. So POMC-CART for decreasing food intake and agouti-related protein neuropeptide Y for increasing food intake. Now, not only does the stomach send signals, but also our adipose tissue sends signals via leptin to both of these neurons. Leptin from the adipose tissue goes to the POMC-CART area. And really, if the fat cells are getting larger or plentiful enough, they should attach to the leptin receptor, the POMC-CART area, and signal the patient to decrease food intake. And on the other end, they should go to deactivate the leptin receptor on the agouti-related protein to cause an increase in food intake. And we'll talk a bit why this all ways doesn't happen as one would expect. Furthermore, with the gut, we have the pancreas secreting amylin and insulin, which also regulate appetite-driven behaviors. Now, both of these areas that have neurons in the ventral nucleus of the hypothalamus then send messages to this MC4 receptor that really determine our food intake, our energy expenditure. So all of these different receptors are potential targets for drug therapy, as they can increase food intake, decrease food intake, and ultimately, at higher levels, potentially affect energy expenditure. So as we go on and talk about the mechanism of the medication, all of these different hormones, ghrelin, leptin, insulin, will be discussed as why they are so important to helping our patients with appetite and glucose control. Excuse me. So of course, we want to make sure our patients are adequate candidates for pharmacotherapy for weight management, and that involves taking a medical history. It's important that we screen our patients from a medical standpoint because they're seeking our medical guidance. We should get their past medical history, surgical history, family history, history of surgeries related to or not related to weight loss, joint disease type surgeries, as well as surgeries for cancers. Weight history should be extensive when we're considering patients for pharmacotherapy, including the onset of obesity, including any particular life events that led to weight gain or weight loss. If there is a particular area where someone lost weight or gained weight very rapidly, you want to really dig into that. Also, history of disordered eating, what previous attempts have been made at weight loss and their results, as well to get a 24-hour food recall. I actually like to get 3 days of food recall because we know our patients don't have even days every single day. I like to get 2 weekdays and 1 weekend day so we can kind of average those out. To determine what their energy levels are at baseline and their purposeful activity. And then on the social side, we want to get an idea of the patient's living environment, who they might live with, who's responsible for their meals or their grocery shopping, if they have food insecurity, what their job is, if they're employed, if they work from home now, we have to think about that. How they're going to follow up with you is very important because a patient who can't adequately follow up will have limited success. And we do want to get information about sleep patterns and as well medications that may or may not contribute to weight gain. And we'll talk about that. So here's a chart. It's not complete, but it gives a good idea of some medications that are commonly associated with weight gain in patients. And we see many of our patients come in on especially this top box antidepressants. And they're on them for decades sometimes. And many times no one's ever thought to correlate them with weight change, or they've moved many times and the medication gets prescribed and represcribed without really much consideration. So if we see these patients on these meds, we want to assess where they're correlated with weight gain. And if possible, we can determine if there's any alternatives in conjunction with the prescribers of these medications. Excuse me. There are other medications that patients do have to take. For example, I saw a patient today on aromatase inhibitors for 10 years. And at year 5, her breast cancer specialist switched her from tamoxifen to anastrozole, but the patient still continued to gain weight. And now that her 10 years is over needing those medications, she was not able to get the weight off, and she actually continued to gain weight. So it's important to know that when weight gain is due to a medication, we many times need pharmacotherapy to help negate the weight gain potential of those medications, which may be essential to our patients. And on the right here, I just want to point out there are some alternatives which can be associated with weight neutrality or weight loss. All right, so it's good to get some good information on our patients at baseline. I like to get labs if they haven't had them in the last 3 months. You can see some of the labs here. It's also prudent to get vitamin D if it has not been checked, as we find that it's deficient in about 80% of our patients with obesity. And we want to supplement that to improve their bone health in the future. Of course, we want to do a relevant physical exam, cardiac exam, pulmonary, neck exam. You'll see is important, some of the medications. Looking at distributions of fat to determine if there are any fat cell disorders such as lipedema or lymphedema. If there are any potential signs of cortisol overproduction, such as purple vertical striae on the abdomen, that can warrant more workup in the endocrinologic fashion, looking at cortisol, et cetera. It's not uncommon that we find acanthosis nigricans in our patients with insulin resistance. So these are things we want to really get a good physical exam, not only at baseline, but at follow-up. And then the body composition is important because we need to not only look at BMI, which I think we can all agree on has some inequities in its ability to diagnose increased adiposity, but also looking at patients' body fat percentage using DEXA or body composition analyzers, waist, hip circumferences. I also do neck circumferences to screen for sleep apnea in my patients. So it's really important that we look at some of these other measures beyond BMI, because as I'm sure you're aware, when we get the prior authorization, the patient does not hit a certain BMI cutoff, they may not get the medication. But if we can prove they have obesity by body fat percentage or increased waist circumference, we have more of a message to send the insurance companies that this patient may not fit the norm, but does have excess adiposity. So looking at pharmacotherapy, it's first that we determine what the patient's indications are. First, we want to make sure that the patient, and I'm going to speak mainly about adults today. We can talk about which medications are approved in adolescents, that the patient has made some attempts at weight loss without medications. So that's diet, exercise, behaviors for at least 3 months. And I think there are very few adults who have not tried to lose weight, who are presenting to our obesity practices for at least 3 months in their lifetime. And these are the BMI cutoffs for medications right now. Again, you can use body fat percentage or waist circumference, but you can also use pharmacotherapy in those who have not achieved adequate weight loss after bariatric surgery or endoscopic procedures, or have regained weight or have recurrence of weight after these type of procedures. Here's a list of our current FDA-approved medications, and here's a list of our off-label medications. And we'll discuss a few more others as well. It's important as we go through the slides to determine what is considered to be efficacious. And generally with the medications, once you've achieved the goal dose, if a patient has not achieved greater than 5% weight loss after 12 weeks on that medication, they are considered a non-responder, and other modalities should be considered. So we have a couple of cases. We can see if Dr. Kohli or Dr. Jason Ghani can read the cases. Thank you.
So Dr. Kohli's here, so I'll let her continue reading.
Yeah, thank you. So the first clinical case, so we have a patient, MS, is a 30-year-old female with a BMI of 32 kgs BMI of 32, who presents for weight management after minimal weight loss with diet and exercise. Past medical history is knee osteoarthritis, and at home they take Tylenol and oral contraceptives. Family history is positive for hypothyroidism in the mother and then lung cancer in the father. Social history, no alcohol, smoking, or drug use. Their teacher lives alone, and insurance recently lapsed, which means no medication coverage. The review system shows that the patient has a positive weight increase, hunger, as well as knee pain, and no chest pain or palpitations. When we look at the physical exam, including the vitals, we see that for the most part, their vitals are completely normal. They present with a weight of about 205 pounds. Cardiopulmonary exam is normal. EKG, normal sinus rhythm with a QTC of 450. Then, one of the options that we can talk about first is phentermine. So phentermine is a norepinephrine releasing agent. This would be an ideal medication to start in this type of patient because they don't have any of the cardiopulmonary risk factors that we look out for. And because it's generically available, it is one of our most affordable medications. So when we talk about phentermine, the mechanism of action is norepinephrine releasing agent, and it will cause appetite suppression. We see a total body weight loss of about 6% when patients are on the 15 milligram dose versus a 1.71% with placebo alone. Adverse effects include dizziness, dry mouth, insomnia, irritability, hypertension, tachycardia, which is why we take those baseline vitals, which is why we screen for any past medical history of cardiac history, basically. And that's also in terms of, because it does stimulate like a stimulant type of effect, we do recommend that they take this medication early in the morning so it doesn't affect their sleep, resulting in insomnia. And similarly, they stay hydrated to avoid some of these side effects. But true contraindications include any cardiovascular history, hyperthyroidism, angle closure glaucoma, MAO inhibitor use in the last 2 weeks, and pregnancy and breastfeeding. The different types of doses, so a very low dose would be 8 milligrams TID. This medication also is known as Lamira, but truly, we start at the 15 milligrams once a day dosing early in the morning, and then we have the ability to escalate to 30 milligrams, then 37.5, or you can take half a pill BID. Again, if it's affecting sleep, then we try to do once a day early morning dosing, 1 to 2 hours before breakfast. But that is what would be ideal for our case 1 patient. Okay, so basically after we start them on phentermine, they reported a 15-pound weight loss after 3 months on phentermine, and vitals continue to stay stable, which is really important that we check that heart rate and blood pressure on every subsequent visit. And patient is pleased with the results after taking phentermine, but now complaining of dry mouth and mild anxiety. So she wants to explore other options. Other options, we can talk about the different types, but what we see here is a combo pill with phentermine and topiramate. The mechanism of action here is we see the same norepinephrine releasing properties that phentermine has, while topiramate will have the additional benefit of blocking voltage-gated sodium channels, calcium channels, and inhibits carbonic anhydrase. In totality, it will cause a higher appetite suppression versus phentermine alone. So we see a total body weight loss that is a little bit higher, 9.8 compared to, if you remember, the 6% that we saw with phentermine alone. And this is also in comparison to 1.2% total body weight loss with placebo alone. And that total body weight loss we see at the 15 and 92 milligram dosing. Adverse effects, so we're seeing the same type of side effects with phentermine that we saw previously, which is going to be the dry mouth, the insomnia, hypertension. We do have to be mindful of topiramate side effects, which include like the paresthesias, dysgeusia, and then similarly, lab abnormalities would include metabolic acidosis, elevated creatinine, and then hypoglycemia. Contraindications are very similar to phentermine alone, but also include hyperthyroidism. And then the other ones are similar: angle closure glaucoma, and then MAO inhibitor use within the last 14 days, pregnancy or breastfeeding. Pregnancy and breastfeeding are pretty widespread throughout all of the medications, mostly because the large-scale studies don't include enough patients that were pregnant or breastfeeding to safely say that it's okay in this population. So when we look at the dosing, 3.75 milligram 23, that combo pill is where we're starting off with, and it's extended release daily for 14 days. And then you can increase to the next higher dosing of 7.5, 46 milligrams daily. Now, when do we decide whether this medication is efficacious for a patient is we generally try to have them on a medication for 12 weeks. And if they're unable to achieve about 3% of their total body weight loss on a 7.5 46 milligram dose, which is the highest one, then this is not the medication for them. So we're going to discontinue the combo pill, which is known as Qsymia, if 5% weight loss is not achieved after 12 weeks on the maximum dose of, you can go up to a maximum dose of 1592. And then the way that we're going to discontinue it is we're going to gradually take a dose every other day for at least a week prior to stopping it altogether, just because with topiramate specifically, you don't want to precipitate a seizure. Then another medication that is possible, especially if there's no insurance coverage, would be orlistat. This has decreased in popularity more so in recent years with the advent of all of the new medications, but it is a lipase inhibitor. Overall, its effect is a caloric deficit by the unabsorbed triglycerides. So basically, when taking very fatty foods, those triglycerides are not absorbed and then excreted out. So we'll see a total body weight loss of about 8% at 1 year with 120 milligram TID dosing versus 5.8% with placebo alone. Adverse effects, obviously, we're not absorbing these fatty triglycerides, so you will have, and it gets excreted in our stool, so you'll see steatorrhea, which is a lot of stool that's floating in the toilet, oily spotting, fecal incontinence, cholelithiasis, and which is gallstones, and then increasing the urinary excretion of oxalate, which can in turn lead to kidney stones. Contraindications is chronic malabsorption syndrome, cholestasis, pregnancy, or breastfeeding. So when we look at clinical case 2, this is a I think it's a Mr. Yes, DA is a 54-year-old lawyer, presents with a 20-pound weight gain over the last 1 year. So more of a kind of recent weight gain. He states that since the office began sharing a space with a catering company, he has found it difficult to avoid baked goods that are in the lunchroom daily. The weight has been making him feel down, and he's worried he may develop medical problems. he was given phentermine for about 2 months, and while his appetite was suppressed, he's still having very intense cravings for sweets and has not lost any weight. There's no past medical history, does not take any medications, and he has normal physical exam and labs. So when we talk about stress eating, sweet tooths, we kind of talk, a good option here would be naltrexone and bupropion, so also known as Contrave. So the mechanism of action here, you might be familiar with both of these medications separately. So naltrexone is an opioid receptor antagonist, and then bupropion is an aminoketone antidepressant, as well as a norepinephrine dopamine reuptake inhibitor. Overall, the effect is appetite suppression, but it's great to use this to target patients who have more of a stress eating pattern. Specifically, they're unable to have, they kind of present it as like sweet tooth, or they talk about different stressors or mindless eating. Total body weight loss that we see is 5% at around 56 weeks versus 1.3% alone with placebo. Adverse effects are nausea, vomiting, a lot of GI issues, mostly diarrhea, constipation, headache, dizziness, and insomnia. So the separate contraindications for these are, with naltrexone and bupropion, it's the same as individually as well as this combo pill. So any history of suicidal behavior, again, MAO inhibitor use within the last 14 days. And then if they are using opioids, as naltrexone will inhibit that. And then any seizure disorder, as bupropion does decrease your seizure threshold, and anorexia or bulimia history, any abrupt discontinuation of alcohol, benzos, barbiturates, use of anti-epileptic drugs, and then again, pregnancy or breastfeeding. So we are going to say that this medication does not work for the patient if at 12 weeks we see less than a 5% weight loss. And then this is a medication that we would want to taper down to avoid any seizures, any side effects. So in the way that we first taper up, it would be week 1, we start with 1 tablet in the morning. That's it, nothing in the evening. Week 2, we're going to do 1 tablet in the morning and 1 tablet in the evening. Week 3, 2 tablets in the morning, 1 tablet in the evening. Then by week 4, they're on the full dose. And so if they're on the full dose and then they haven't achieved that 5% weight loss in 12 weeks on this full dose, then this wouldn't be the medication for them. And then in order to start them on something else, we would have to taper them down off of this medication. So after 4 weeks of using bupropion, DA reports he was able to titrate up to the 4 pills a day and no longer making trips to the lunchroom for snacks. And he has lost 10 pounds and then had an additional benefit of overall mood improvement. So our next most popular, topic usually is often the GLP-1 receptor agonist. And a lot of people have been familiar with these. We have GLP-1 receptor agonists that are specifically FDA approved for weight loss. And then we have ones that are specifically for diabetes with the additional benefit of weight loss. Here we're talking about the FDA approved ones. And that would be liraglutide at the 3 milligram dose, and then semaglutide at the 2.4 milligram dose. The GLP-1 receptor agonist, the overall effect would be appetite suppression through various ways, but the most prevalent manner is by slowing gastric emptying. The best way we kind of talk about this is when patients do eat a small amount, it does sit in your stomach, creating that feeling of fullness for much longer, overall leading to a decreased intake. But the adverse effects are going to be caused by that same mechanism. So when that food sits in there for a while, patients often complain of nausea. They have constipation because it is slowing down your gastric emptying. And then similar receptors that are on the stomach that they target are also on the pancreas and thyroid. So we do have a few cases of acute pancreatitis. And then anyone with excess weight loss will be at risk for gallstones. And then because this is a medication originally also used for diabetes, we see that hypoglycemia. So the total body weight loss for liraglutide at the 3 milligram dose is 8% at 56 weeks versus 2.6% with placebo alone. And then with semaglutide, obviously we're seeing these great numbers of 18% at 68 weeks versus 2.4% with placebo alone. The main things that you want to screen your patients for is anybody who has a personal or family history of medullary thyroid cancer, any of the MEN2 cancers in the family, and then pregnancy or breastfeeding. While it's not a absolute contraindication, I still ask patients if they've had any recent episodes of acute pancreatitis as well. Personally. And then, so when we look at the liraglutide dosing, so week 1, we're going to start them off at 0.6. Usually this is mostly like a placebo dose just to see if they have any adverse effects. Week 2, we do the 1.2 milligram per day dosing. Week 3, they're going to be on 1.8 milligrams per day. And then week 4, it's missed here, but it would be the 2.4 milligrams per day. And then week 5, they would be increased onto the 3 milligrams per day dosing. But we're going to discontinue liraglutide if less than 4% weight loss was achieved at 16 weeks. So it's not that the patient has failed these medications, the medication has failed the patient, and it just is not efficacious for them. And then semaglutide is an option. And the main difference here is you're seeing that this is a weekly medication versus daily, which is often preferable, especially when patients are kind of queasy about injecting themselves. So with semaglutide, we're going to start off again at almost a placebo dose just to see if they're able to tolerate the side effects, which is going to be the 0.25 milligram weekly for the first 4 weeks. Then we're able to increase it to 0.5 milligrams once weekly for 4 weeks, then 1 milligram, and then 1.7 milligrams weekly for 4 weeks, and then 2.4 milligrams weekly. Yeah. And then setmelanotide. I know this isn't a familiar medication for most, mostly because this is very specifically targeted to our patients with genetic chromosomal mutation. So this is an MCR4 receptor agonist, and this is specifically when we see the going back to the pathway that Holly was talking about, the patients that we're specifically targeting here, if they're 6 years and older and they have an obesity that is secondary to POMC deficiency, or if they have a PSK1 deficiency or a leptin receptor deficiency. That's why this genetic testing is available, and we're able to really, it's wonderful that this medication is even available, because in the past we've always been noting the deficiencies, but not having a medication that has been FDA approved for this. So it's a daily subcutaneous medication for patients who are between the ages of 6 to 12. It's a 1 milligram daily dosing for 2 weeks. Then based on their tolerability, titrate them up to 2 milligrams once a day until they're able to tolerate the 3 milligram dose, which is the target dose. Now, if they're older than 12, then you can start them right off at the 2 milligram daily dosing for 2 weeks. And then based on their tolerability, be able to titrate them up to that target dose of 3 milligrams daily. The main side effects for this are going to be nausea, vomiting, headache, hyperpigmentation, and priapism. The efficacy is we're going to evaluate weight loss after 1 year of treatment. So if they've not lost at least 5% of their baseline body weight or 5% of their baseline BMI for patients aged less than 15 or 18 years, we're going to have to discontinue this medication as it's unlikely that they're going to achieve meaningful weight loss with this alone. And then tailoring pharmacotherapy. Sorry, Holly, I don't know which slide that you wanted to start off with, but I can continue if you'd like.
I can try to pick up here. We'll see. I'll let you know if it would help, which I might. So that was excellent. Thank you. And, you know, we may have used all these medications at different times. I've definitely prescribed all of them. And I always have a algorithm. I think about safety first. What will be safe for the patient? So you need to know your contraindications. Efficacy, what is of the available options for safety, what is likely to get the patient the most benefit for their obesity, but also maybe something else. And then next we think about cost and we have to think about availability. So when we're tailoring the efficacy piece, you want to look at if the patient has anything else that will be beneficial from the medication. So those with diabetes, GLP-1 agonists, we know, great for this. Depression, the bupropion can be useful for that. The topiramate can help patients with migraines, also nighttime eating syndrome. There's evidence for this. And we've seen very good off-label use of metformin outcomes in patients with antipsychotic induced weight gain, as well as with the GLP-1s. Now, we can also use these medications in combination with procedures. And you can see some of the outcomes here. I won't go through the numbers just because of my voice, but we combine the balloon with medication. We can get weight loss that's more like a surgery, because you know that intragastric balloon has to come out. You need a plan for when that device is discontinued. Endoscopic sleeve gastrectomy can get weight loss in the 25% range versus about 20% alone when we add medications. And the bariatric surgery can just boost weight loss overall when we combine that with medications. So I get this question a lot. Can I use medications in patients who have surgery? The answer is absolutely yes. But we have to think about safety and efficacy. So we know that we're targeting insulin resistance. We get sort of the side effect of weight loss. And again, I won't read this entire slide, but you can see the differences in some of the classes of medications and their use as adjuncts to other medications for weight loss. So if we're getting 5%, say with metformin or SGLT2, that can be beneficial in a patient who's on a GLP-1 but needs an additional 5%. Or if a patient can't get a medication that will give them 10% weight loss because of insurance, you can put 2 medications to give them 5% together. So we can combine therapies to get the best outcomes. And feel free to use this as a guide in treating your patients. All right, so we'll talk about tirzepatide. I'll try to push through this. So tirzepatide has dual agonism, GLP-1 and GIP. And what I've highlighted here in the diagram is some of the benefits of GIP, because we don't really know a lot about GIP. There's so much emphasis on GLP. And one of those that we don't see with any other medication is increased energy expenditure. So the GIP helps the GLP agonism work better, but also increase in energy expenditure and the effects of subcutaneous WAT. So in increasing the insulin sensitivity of white adipose tissue, we see fat cells get smaller. We see decreased inflammatory immune cell infiltration. So this is helping our patients in more ways we realize. And thus with tirzepatide trials, we saw upwards of 20% and greater weight loss. So this is some of the results from the SURMOUNT-2 trial, demonstrating, depending on if you're looking at the full population or the estimate data, 20.9 to 22.5% weight loss. One thing I want to point out is not everyone loses weight. And this can be disappointing to someone. They see all their friends losing weight on the medication, and they may be in this 4% or 15% that does not achieve 5% weight loss. This is why we have other medications to help our patients who may be non-responders. And some of our pipeline medications are getting close to that 100%. This is just some of the overall data. And I want to especially point out part B here. You see different doses of tirzepatide. This is important to know because just if a patient does not necessarily tolerate a lower dose, this does not mean that can't be efficacious for them. So with 5 milligrams, we saw about 16% weight loss, which is very impressive. 10 milligrams, 21%, and 15 milligrams, 22.5%. And keep in mind, each one of these lines is an average of thousands of people. So some lost more, some lost less. All right. So cagrilintide, you may have heard this is amylin analog, but it's getting more popularity, especially in combination with semaglutide, because alone, we saw about 6% weight loss to 11% weight loss. But when combined with semaglutide, there's some really promising data. And we saw that this did have some benefits versus liraglutide in studies. So this is something in the pipeline we might see alone, but definitely in combination with semaglutide. And here are a few more medications in the pipeline. I'm sure you've read lots of articles about these. Pemvidutide, there's a BI drug that has a number. Retatrutide, the triple G, very impressive results, close to bariatric surgery. Pfizer and Lilly have other GLP-1 agonists that are oral that patients are really looking forward to. There's another form of oral semaglutide of higher doses from Novo Nordisk. And bimagrumab, it's a monoclonal antibody that really helps patients increase their muscle mass. So there's evidence that this can help with sarcopenic obesity, but also combined with the current medications, we can help people lose fat and also gain muscle. So here are some resources that you can use to learn more about this. And these are also some of the resources we use to make this presentation today. And we'll take some time, about 15 minutes for questions. Thank you.
Thank you so much, Dr. Lofton and Dr. Kohli. That was a fantastic lecture. I think so apt, especially during a time where we have a lot of shortages across the range of various GLP-1s to review what some of the other medications are that are available in our armory to treat patients for weight management. We do have lots of questions, so I'll just read them off for you, and then hopefully we can get some answers to these. So first question is, can you start a patient on 1 or 1.7 milligrams of Wegovy if they can't find the lower doses?
I'll start. In my experience, if patients naive to a GLP-1, never taken it, I have seen really bad outcomes with doing this. Patients have had severe vomiting, end up in the ER because they have very rapid decrease in their gastric emptying. So you can do that, but be prepared for some significant side effects.
I agree. I've seen the same. So I know it's sometimes tough for patients to start off on that like placebo dose of that 0.25, but it's really beneficial for kind of avoiding just like quick escalation and just assessing like tolerability.
The next question is, are you able to get a prior authorization for Mounjaro in patients without type 2 diabetes?
They really want you to use it on label now. I mean, we're talking about in New York, tri-state area. I don't know what other states are doing, but they're actually making you prove diabetes with labs now.
Yeah, same. I haven't had much, I guess, luck with trying to even put like pre-diabetes or metabolic disorder. So I think at least in New York, it's just a cut and dry having diabetes, especially with the shortages.
Okay, next question says, thanks for the great lecture. Is there any concern with using phentermine in patients on SSRIs or SNRIs regarding potential for increased serotonergic effects? Sorry.
So personally, I haven't had any in terms of like being concerned for serotonin syndrome or anything. I haven't had any patients who have developed serotonin syndrome, but there have been interactions or some noted reports with phentermine with SSRIs and SNRIs. I personally haven't had them in my practice so far, but I'm sure Dr. Lofton's seen a few more patients than I have.
Any comments on that, Dr. Lofton?
I think you're muted.
I'm typing my answer.
Oh,
That's okay. Don't worry. We're going to spare your voice a little bit
oh
today.
yeah,
Go
that's
back. Okay. So the next question is, how long can we use phentermine? 3 months? And I guess the counterpart was, if Qsymia contains the same drug, why can we use it for a longer duration?
So with phentermine, you can, I've actually had great luck using it for very long term. The reason that there's no FDA approval is just because it is a generic drug and so cheaply made. There's really no cost benefit for companies to do those long-term studies. And so you can use phentermine at least indefinitely. In terms of Qsymia, it's not been the same. There are again, no long-term studies, but I've not had the same experience using Qsymia longer because it does contain the topiramate component of it. But I'm sure Dr. Lofton is also contributing.
Yep, I think she'll be typing in the chat box if she has extra to add. The other question is there any true pharmacological benefit of prescribing or using Contrave versus prescribing bupropion and naltrexone separately as a method to decrease costs?
Yes. So we've actually done this for patients who have not been approved for Contrave specifically. And I've seen similar benefit. There is an added benefit like when Contrave is used together in terms of the patient aspect of it. But in some patients where it's just not been approved, it's been an alternative, especially if nothing else has been approved, and this would benefit them because they have that presence of stress eating. But I've seen a higher efficacy with Contrave, like the actual combo pill. But this has also worked, but just not to the same percentage as weight loss I've seen with the combo pill together.
And I'm just going to cycle back to the, we have an answer. It says from Dr. Lofton, bupropion can cause some anxiety or drug interaction in some patients. So using naltrexone alone can help some patients. Also, just cycling back to the previous two questions, the one about the serotonergic effects. Dr. Lofton responded, I have done this, use low dose in moderate patients' mood. I hesitate with using phentermine if it's with more than one SSRI. And for the other question regarding why we can use Qsymia longer, Dr. Lofton wrote, good question about why we can use Qsymia longer. It has to do with how the label for Qsymia was approved by the FDA. They were more liberal in 2012 than in the 1990s. So those are Dr. Lofton's contributions for that question. Now we're going to continue through. So the next question is for GLP-1s and tirzepatide. If a patient is having good weight loss at one of the initial doses on the taper, can you stay at the lowest possible dose resulting in weight loss and just taper up when they hit a plateau?
Yes, you can. So I've done that. Also, if they're having side effects too at the higher doses and they're able to tolerate. So as long as they are not plateauing and they're having good weight loss, I'm actually fine sometimes keeping them on that dose for another month, and then just making sure that we're not getting stuck there. So that's actually been fine. I've had a few patients stay at those lower doses, and then you get the benefit of not having the adverse effects too at the higher doses.
And Dr. Lofton concurs. And next question, it says, thank you. When do you screen for the MCR4 gene mutation?
So I haven't had too much of that in my practice. So I think I'll defer to Dr. Lofton because it's more of the presence of like extreme childhood obesity. And if they, contain any of the other clinical features so that they present with like albinism, things like that. But I'm sure Dr. Lofton has for more practice with that than I do.
So when you see a lot of patients, you can tell when someone really stands out. And one big factor in screening is hyperphagia. So these people are not just hungry, but they're eating out trash cans. They're bankrupting themselves trying to get food. It's a very unusual type of hunger. It's very commonly defined in a pediatric setting, but sort of a classic phenotype is a person with pale skin and red hair because of the alpha MSH pathway not being activated. And thus why this setmelanotide causes hyperpigmentation. And also these patients have very high BMIs. And often if they fail bariatric surgery, those can be some other clues as to when you want to screen.
Thank you, Dr. Lofton, and thank you, Dr. Kohli. Next question is, we have lots of questions, so that's good. The lecture was very stimulating for everyone. So the next question is, the Qsymia reps mentioned there is less brain fog with the ER formulation versus using phentermine and Topamax generics off-label. Have you seen less brain fog with the name brand versus generics?
Anecdotally, I really haven't. I don't know if Dr. Lofton has, but I really haven't seen a difference in that using the off-label versus the brand.
I'll spare Dr. Lofton a little bit if she has something to add. I'll wait for her response in the chat box and I'll read it out. Okay, so for the next question, it says, when a patient has had weight regain after bariatric surgery, is there any way that they may make any more they may make them any more likely to get approval or a prior auth for other weight loss medications?
So weight regain. So sometimes, I mean, it depends on their comorbidities and their BMI. It comes down to that. A lot of times you don't have the same ability, like for prior auths, you just have to sometimes just choose the choices given. And if there is an ability to add some of the fact that there's that component of weight regain, but it's hard because if they don't have the specific comorbidities that they're looking for, I've not gotten approved, even though they were at a higher weight before or did have those comorbidities in the past.
Okay. And thank you for that, Dr. Kohli. And just going back to the question regarding brain fog and Qsymia ER formulations versus generics, Dr. Lofton just wanted to add that the doses of Topamax are only up to 92. So it's possible, but it depends on the patient. So now to the next question. It says, I have noticed that patients who I switch from maintenance dose semaglutide to tirzepatide without taking a 3 to 4 week break often are unsatisfied with the effects and often need much higher doses to see the effect. Have you had any experience with this?
I'll chime in. So I think patients always think that the first GLP-1 they took works the best because they got the most weight loss. So if you look at the data and they got 8% weight loss with liraglutide, and then they got 18 with semaglutide, and then they got 23 with tirzepatide. They only see the difference in each one when you change it, and I think it's really more the perception. It's whichever one you take first works the best.
Okay. And I will also read out Dr. Lofton's previous answer, just so we have that. So the answer to the previous question was also about, bariatric surgery and kind of getting approval for weight regain post. Dr. Lofton mentioned, I have not seen that history help a patient get approved since the insurance make up the guidelines for prior auth, and they don't always mirror the evidence. And then I think we'll have one final question here. So when someone loses nearly all hunger on semaglutide/tirzepatide, can they eat just when hungry, or is there a minimum grams of protein requirement or calorie minimum?
So I try to make sure that they do have a minimum protein amount, just because you want to make sure that they're not losing muscle mass and that it is targeted fat that they're losing. Generally, it depends also on the specific patient, depending on how much they are eating and how much weight loss they have lost, just because we have to, and this is kind of going back to the previous question too, when you're switching between different medications, as you continue to lose weight, your metabolism also does slow. So there is that component of if they continue to only eat so little, is that are you able to maintain that as your metabolism slows? And then you do want to be mindful about not losing muscle mass and that you really are targeting fat. I personally try to make sure that they are hitting a certain minimum amount of calories, but a lot of that is also, you're looking at the quality of the calories, and you want most of that makeup to be a protein amount, which can sometimes be anywhere from like the 0.8 milligrams of protein per kg versus higher amounts. But it's a nuanced question, because we also talk about their kind of breakdown of overall calories per the day and breaking each thing down. So I feel like it's a tough question to just kind of say, hey, this is just a number that works for everybody. And that's what's the benefit of doing the body compositions as they continue to lose weight, and then we have a better idea of what amount of calories and how much of protein they can eat too.
And Dr. Lofton added, I agree with Dr. Kohli. If a patient is really eating nothing or has symptoms of orthostasis, syncope, hypoglycemia, dose should be lowered. Okay, and we have one final question. We're going to squeeze in last minute because this lecture has been amazing. And the last minute question is, it says, sorry, last minute question. Do you switch from Sema to Mounjaro if they had a reasonable response to Sema but want more weight loss?
Yeah, so you can. A lot of times, if they're kind of plateauing and they've still not hit their goal, then you can switch them to Mounjaro. You just have to be mindful of the doses and how to kind of, it's not a straight one-to-one dosing, but.
Yep. And Dr. Lofton also added, based on the science, the patient could expect another at least 5% weight loss. Okay, well, we've wrapped up our lecture and our Q&A session. Thank you so much, Dr. Kohli and Dr. Lofton. It's an absolute pleasure and honor to have you. We've gained so much knowledge, and I am really, really thankful that we had this lecture to go over all the pharmacotherapy, get an update and refresh our memory, and really, really important medications that we've had out there, and to kind of help us survive through some of these shortages that we're encountering, and also a glimpse of what we're going to find in the future. So thank you so much. And everyone else, make sure to stay in tune with the Tri-State Obesity Society lectures that are here. Make sure you visit our website, join for membership and for other events. All right, with that, having a good evening, everyone, and hope to see you at the next round. Take care. Bye.
Yeah.